Okay, so welcome everyone to the fifth session of our 2025-2026 C3 series. This is going to be on treatment planning with nuclear medicine and brachytherapy. We have two great speakers today. We have Dr. Julia Brosch-Lenz, medical physicist from Universitätsklinikum Augsburg, Germany, and Dr. Alexander Rink, medical physicist from Princess Margaret Cancer Center in Toronto. So just before we get started, I'm located in Calgary here, so I'm just going to give a brief landed acknowledgement for that. So we're located in the heart of Southern Alberta, and we pay tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, Tsuut'ina First Nation, and the Stoney Nakoda. The city of Calgary is also home to the Métis Nation within Alberta. So just for the next few minutes, we'll have some opening remarks. Then we're going to lead with the presentation by Dr. Julia Brosch-Lenz. Then we will follow that up with a presentation by Dr. Alexander Rink. And then we'll just have some closing remarks to thank our speakers and to go through anything else. So during these talks, please, I think everyone else has their mics muted, but please keep your mics muted except for our speakers. If you do have a question, either our moderators, Charzed or myself, will call on you. You can ask your question during the actual session, and we'll interrupt our speakers kindly. If you don't feel comfortable with that, feel free to write your questions in the chat, and either myself or Charzed will read out the questions. This session is being recorded, so that's a typo there, and it will be shared via YouTube.
Okay, thank you, Fletcher. Do you hear me well?
You're good.
Yeah. Okay. So the COMP Student Council mission is an education subcommittee which is involved with the student and trainee interests in medical physics across Canada. So our mission is to advise the COMP board through the education committee on matters of importance to COMP student members, assist COMP in attracting and training student members, organize social, academic, and professional development events for students in the academic year, and the COMP annual scientific meeting ASM, which is happening in Vancouver this year, along with the AAPM. And also we help create a strong student committee. So if you can move, yes. So we have we run different initiatives, among which student events in the annual scientific meeting, like Young Professional Workshop, Residency Fair, Science Spoke Consistently, or MedPhys Slam for this year, and the ITA Travel Award. So also we organize bi-monthly research discovery seminars. Here, students showcase their latest results and make connections with their peers. And also we have the ambassador program, so we keep in touch with the medical physics Canadian programs in other universities. And last but not least, in the COMP Career Catalyst Seminar Series. Yes, the next slide. So, which are a professional development series for students, where we invite medical physicists or professionals to present in different subjects who want to develop their skills and learn from experienced speakers in medical physics. So our sessions are recorded and are available on YouTube on our link tree that you can scan on the QR code here. Okay. So our next speaker is Dr. Alexandra Rink, medical physicist in Princess Margaret Cancer Center in Toronto.
Thank you so much. Okay, let me see if I can share my screen. All right, so it's going to be old school. I apologize. All right, so I'm not going to bother with the actual presentation. So the outline for this is I'm going to slowly go through the introduction to what brachytherapy, dosimetry around brachytherapy sources means, talk about a little bit concepts and definitions when you talk about brachytherapy in general, because there's a lot of very specific nomenclature to this type of treatment. Give you an example of what it requires to calculate a dose with one specific methodology, which is TG43, which is at this point still the predominant method of calculating brachytherapy dose in commercial products. And then we'll go over a planning example in a treatment planning system. So brachytherapy comes from the Greek word brachys, meaning short distance. It's a technique where radioactive material is placed inside or adjacent to the actual target tissue. And normally when we talk about brachytherapy, we talk about something called implants. And an implant just means it's a completed assembly of either sources or catheters that are required for brachytherapy. Now, broadly, they can be put into temporary implants, which is the implant that is inserted and then removed either after minutes or days. Or a permanent implant, which is what most people are familiar with when they think about brachytherapy, where you insert the radioactive material into the tissue and you leave it there forever to deliver dose over basically infinity. And the most common example of that would be permanent seed implant for prostate cancer. The other definitions that people need to be aware of is the methodology of inserting either the radioactive source. So we have broadly intracavitary, interstitial, interluminal, and surface. Oh, sorry, by the way, for the purposes of today, I'm only going to talk about temporary implants, and we will not cover any treatment planning for permanent implants. So going to other definitions, there's intracavitary, which is where you position the applicator into body cavity, which in proximity to a target tissue. Interstitial would be surgically implanting sources or catheters directly into the target tissue, percutaneously, for example. There's intraluminal, which is when you insert a line source into a body lumen, and surface, where you position the applicator containing catheters or sources to treat dose to a surface. So again, for purposes of today, just because we only have like 40 minutes in total, I'm only going to focus on the intracavitary and interstitial approach. So on the left here, you see intracavitary, an example of an intracavitary applicator, which is used for gynecological brachytherapy, specifically cervical brachytherapy. So on here, for example, you see the little black part, which is called a tandem. And this tandem, when the applicator is positioned, goes through the cervical os and into the uterine cavity of the patient. The rest of the applicator, this white part right here, sits basically right underneath the cervix in order to deliver the, sorry, there's stuff in the chat, do I? No, okay. Fletcher, you'll interrupt me if questions for me, right?
I will.
Okay, perfect. So the white bits are called ovoids. We also have other names like ring. We can have a tandem and ring, for example, instead of a tandem and ovoids combination, but basically it sits right under the cervix and it delivers the dose to the cervical mass. And then with this type of applicator, this is called a Venezia applicator from a vendor called Electa, and it's not because I'm trying to advertise Electa, it just happens to be the vendor that we have our brachy equipment from. There are other vendors that have similar equipment, but basically it has holes here. And in this particular situation, you can see these white pieces. Those are the catheters that are inserted into the holes, and that allows you to interstitially puncture both through the cervix and through the uterus, and put the oblique ones, like the one here, potentially into the perimetrial space if the patient actually has perimetrial invasion. Another example of interstitial is here. You can see interstitial catheters to the perineal template. In this particular case, this is a male patient, but similarly, you can imagine that you can insert the catheters through the perineal of a female as well, and we often do. It's not an example I'm going to give you today for treatment planning purposes, but just know that that is always an option for both prostate, HDR cancer, and cervical brachytherapy. Okay, so if you put these, so notice there's no actual radioactive material in any of these things. All of these things are effectively voids or these are applicators to an extent that go inside the patient, but they're hollow on the inside. So how do you get a source inside it? So what happens is, you can imagine, in this case, this is connected to something called a check ruler for the purposes of quality assurance. But you can imagine that you can connect these types of tubes, they're called transfer tubes, and you can connect them to all of the applicators and the catheters that you've implanted into the patient on the one side. And then on the other side, you connect it to what is called an afterloader. And this is what a remote afterloader roughly sort of looks like. The remote afterloading means that the radioactive material is positioned after the fact into the catheters or applicators. So it's not done manually, which used to be the very old-fashioned method of positioning radioactive material into the patient. So the way the the afterloader is actually a somewhat simple device. You can kind of sort of see a schematic of what it entails. It has so on the surface here, you see something, it's called an index surface. And an index surface is just numbers from 1 to whatever, let's say 1 to 30, that says which channel is basically numbers the channels. And at any point in time, if the afterloader is executing something called a treatment plan, what it does is it knows, for example, that I'm going to have to go to channel number whatever. Let's say channel 1, I'm going to have to go out to a particular distance from the index surface, and that's usually how it's measured. So, let's say 1,254 millimeters. I'm going to go 1,254 millimeters from the index surface, and I'm going to pause a certain amount of time at this position, and then move to a different position, and so on. And that's what treatment planning does, is basically we communicate this information from the treatment planning system to the afterloader in order to execute the plan. But what the afterloader does is, again, it has the source stepper motor. So there's the stepper motor that actually manages the radioactive source itself. But we also have something called a check cable, which basically goes out before the source does and makes sure that there's no kinks in the catheters, that all of the connections are done properly. And it's basically a safety check to ensure that all of the connections are correct as much as possible, and that there's no any kind of friction that would cause issues in deliverability. So basically, the plan is deliverable. So I'm sure you know the concept of dose. It's basically just energy per absorbed mass, which is in gray, or joules per kilogram, and dose rate is basically dose per either hour, minute, and so on. Again, we can talk in brachytherapy about low dose rate, medium dose rate, high dose rate, pulse dose rate. The definitions doesn't matter for the purposes of today. I'm going to talk about high dose rate brachytherapy. So the source is highly radioactive, and basically the treatments happen in minutes, definitely less than half an hour, and delivers quite a high dose in that amount of time. So in today's world, the HDR afterloaders have either a cobalt source in developing countries, or in most of the world, we actually use a radium-192. Quick history thing: the natural iridium was actually discovered in 1803, but it's actually man-made iridium that we use in the afterloader. And it was first made in 1936. Neutron capture, the 1930s was the time where everybody was shooting neutrons in just about everything and discovering all sorts of new man-made radioactive materials. So it was discovered by Amaldi and Fermi. It has a half-life of about 74 days. Although it is technically a beta emitter, it's not the beta particles that we use for the purposes of treating the patients. It's actually all of the downstream gamma ray emissions, as you can see on both sides, that are actually useful for the purposes of radiotherapy. And so depending on the construction of the source and the encapsulation, the average energy that we get from iridium-192 is about 380 keV. And iridium-192 has been used in afterloaders since about 1960s. Okay, so how do you actually calculate the dose from something like an iridium-192? We now use something called task group 43, so task group from APM. APM, if you don't know, I'm sure everybody does on the call, but it's American Association of Physicists in Medicine, and task groups are basically publications from, task group reports are publications from task groups on a particular subject matter. So in this case, there was a TG43 and various updates and amendments that were published, and it aimed to simplify the dosimetry around its source. So there were several things that have made TG43 unique compared to its predecessor. One of the things is TG43 now has to have consensus data. So in the clinic, I'm not allowed to simply measure my own dose around a source and enter it into a treatment planning system. Consensus data requires a minimum of two things. One is Monte Carlo calculations around the source, and one are measurements around the source. And ideally, those are close enough together to warrant calling consensus data. And so that's what is required, and that's kind of managed by a different group of people. So we have consensus data, and the consensus data allows us to have all of the values within this equation. So I'm just going to quickly talk about what the equation is. So this is a dose rate at any point around the source, a distance r and an angle theta with respect to the line of the source. And all of these values are source specific and calculation specifics, and I'll cover that in a second. So when I, as a physicist, get the source for iridium-192, all I'm actually checking is that the specified air Kerma strength from the vendor is as expected. And I'm not going to go into the methodology of how I check that, but that is one of our jobs, is to actually make sure that the strength of the source matches what the vendor tells us it is. So the air Kerma strength, which is this SK, is basically just air Kerma and vacuum due to photons at 1 meter on the transverse plane. So if I take my source and go all the way 1 meter out, that's what my air Kerma strength is. In vacuum means that I'm pretending that there's no air, and I'm correcting for photon attenuation and scattering in air as well as nearby objects. So this is done using something called a well chamber that is calibrated and traceable. And air Kerma strength is specified in something called units, and it's 1 microgray meter per hour. And there's this cutoff, which basically just excludes low energy X-rays because they're effectively, once you get into tissue, which is effectively where we want to know the dose, they don't get past the 1 millimeter. So we ignore those really low energies. So the dose rate constant was the second value here. And basically it is specific on the radionuclide and the internal design of your source. And what it does is it gives you the ratio of the dose in water at the reference point. And the reference point is at 90 degrees, so right here, and 1 centimeter away from the source. So basically it takes your air Kerma strength at a meter, which it just tells you the strength of the source, and says, if you have this source type, and you have this source strength, this is what you get at this nominal position 1 centimeter away from the source. And then you have all of these other correction factors. So there's the geometry function, which basically looks at whether or not you want to, and they exist both for point source approximation, and we can discuss why you would want line source versus point source approximation, or for a line source. And it's just a very kind of almost like a first order correction to say, you know, my source is constructed like so. The thing with the equation, it has to be consistent throughout, because, for example, GL is specific for a line source or a point source. So if you decided you're using a point source, that's what you kind of have to stick with. It neglects any scattering and attenuation, and it basically is like a first order approximation for an inverse square law correction based on approximate model. Why inverse square law? This is a question sometimes I get asked. It has to do basically with the fact that your dose in space is proportional to your fluence. But if you imagine photon emission from a point source and is kind of sort of isotropic, and it is from a point source, then at any point in time as away, your fluence drops off as 1 over r squared. So that's basically why it's 1 over r squared. It's related to the fluence drop off. Okay, so the next one you have is something called the radial dose function. And again, it can be for a point or a line source. And it counts for dose fall off on a transverse plane. So again, looking perpendicular to your line of the source due to photon scattering and attenuation. You can see that it is dependent on the energy of the source. So for iridium-192, it's kind of sort of flat, but for lower energy, and the important part is it's normalized to 1 centimeter. So you can see that as you go down in energies, the drop off becomes really quite fast because of the attenuation with the lower energy sources. Then you have something called the anisotropy function, which is your FR theta. And what it does is, so, you've gone from in air to 1 centimeter, now to a certain distance. And now it says, if I go off this radial line, how does my dose rate vary with the angle? And again, it's normalized to at 90 degrees to 1. And it decreases as R decreases. So as you go further and further out from the source, you can see that the anisotropy becomes less and less important. And at one point, you will be far enough away from the source that it just starts to look like an anisotropic source for all intents and purposes. Again, it decreases as theta approaches to 0 or 180. And again, because of the fact that your source construction itself is anisotropic. And it, of course, decreases as your encapsulation increases, which makes sense because the more encapsulation you have around your radioactive material, the higher, especially at the edges, the more effect it's going to have on your anisotropy at your further away from 90 degrees. If you are decided you want to do this as a point source, you just basically average it over your steradian space, and you have something called an anisotropy function as opposed to an anisotropy factor. Okay, so I guess this is the part where I should, too bad I don't have the slides playing, but this is just an example of the many source constructions that exist. So the ones on the left are actually for iodine, and these are for permanent seats, so they're not attached to anything. But you could see that you can have quite a variability of how any one vendor constructs their source. These are teeny tiny. When I teach this in a course, I usually pass around the dummy sources just so people can appreciate how minuscule these things are. We're talking about less than a millimeter in diameter. So these ones are 0.8. And then usually they're between 4.5 and 5 millimeters in length. Now they're typically loose because these are intended to be either permanently positioned or positioned in some other holder. For the high dose rate brachytherapy, the iridium sources are attached or welded to a wire. Because again, as I've described, it allows the afterloader to push the source out to a particular location. And so again, the dimensions though are quite small. So we're talking about, so this one was, I think the older, this was a variant, I think this was an older microselectron, and this is the newer one. So it's less than a millimeter in diameter, and the capsule is 4.5 millimeters in length. And the tables for these types of things usually like this. This is just an example of a table. But for example, here you see the geometry values for the different sources and how they would, radial values and how they would work with, how they vary with the distance from the source. So when we get a treatment planning system, as a physicist, one of the jobs is to verify what sources we are going to be using and make sure that the appropriate information is in a treatment planning system. Some of the treatment planning systems at this point are very locked down, whereby you can't even modify anything. So at this point, we're spot checking that the table that have incorporated agrees with the published tables effectively. So the example I'm going to give for the treatment planning is for local advanced cervical cancer. That is one of my passions is gynecological brachytherapy. So local advanced cervical cancer is very much at this point patient. First of all, we do adaptive, what I call we're the original adaptive radiotherapy people. So normally it is a boost that occurs at the end of all of the external beam fractions or maybe interdigitated. But the standard of care for LAC or local advanced cervical cancer is chemo-rads concurrent followed by brachytherapy boost. The way it works is there's usually pre-brachytherapy imaging that occurs about third or fourth week into the patient's external beam. We decide what kind of applicator we're going to be using, and then we implant the patient once the patient is anesthetized during their brachytherapy. We are very fortunate at Princess Margaret in that we have an integrated MR-guided facility. So while the patient is anesthetized, we actually have the ability to adjust the implant based on MR imaging. And the reason it's an MR imaging is considered the gold standard for cervical brachytherapy in terms of target definition. And so once we adjusted, we finally have the post-implant imaging, and this image set will have the implant as it is, what we decided was good enough in the patient. And then we do the treatment planning, quality assurance, and treatment delivery. Just a quick plug, the reason we still do brachytherapy as opposed to what potentially may look like more advanced, fancier tools is brachytherapy compared to other boosts, including stereotactic radiotherapy, intensity modulated radiotherapy, against VMAT, and even against proton therapy, although I don't have the slide here, still comes out ahead in terms of improved survival. All right, so if there's no other, let's see if there's any questions. If not, I'm gonna go on to a case. I see there's lots of chats, but I don't know if any of them are for me.
I think you're okay, Alex.
Okay, perfect. Okay, so I'm gonna share my screen. Okay. Yes, I know I'm sharing a screen. Okay. All right, so this is a treatment planning system. This is called Oncentra Brachy. Again, there are other treatment planning systems out there. This just happens to be the one we use clinically. It's compatible with the Elekta equipment that we have. Very fast. You could see that in this particular situation, the patient has already been contoured on. So to quickly describe what you're looking at. So this is a T2-weighted image set that was obtained with the applicator and needles in place. So you have organs at risk, which are your bowel, small bowel. You have your sigmoid, so bowel and sigmoid are contoured as loops. You have your rectum, and you have your bladder. And then in terms of, so vaginal wall here, and then in terms of the targets, you have the residual gross tumor volume at brachytherapy. Usually there's significant shrinkage for most of the patients that occurs during the external beam. So the reason I jokingly say that we're the original adaptive radiotherapy is because we actually adapt to that. We treat the target that is remaining at radiotherapy. To quickly comment, this is the movement, and I still don't think everybody has adapted this, but this is the gold standard now. The previous methodology was prescription to point A's, which is basically just geometric distance from the applicator, and the assumption there was always that the applicator is in the correct spot, which again, I'm not going to go into it, but was never not necessarily always true. Anyways, so if your gross tumor volume, you have your high risk CTV. So your high-risk CTV is your, as per the ICR U89 definition, is your gross tumor volume, your cervix, and any gray zone, quote unquote, visible on T2-weighted MRI. So what does gray zone means? It's literally patchy look on MRI that looks maybe suspicious, clearly doesn't look like healthy tissue, but also is not clearly gross residual disease. So the thought process is that it has macroscopic disease. And then intermediate risk CTV is 5 to 15 millimeter expansion on high risk CTV, excluding the organs at risk unless there was a previous invasion that has regressed, up to and including the original extent of the disease. So that's how it's defined. So if we go, whoops, sorry, I'm already here. If we go back to how I start doing this. So unlike an external beam where, when you image the patient, you kind of create an isocenter on the patient. And then in order to treat that patient, you line the patient up with the isocenter of the machine. The treatment planning system doesn't know anything about what is in this image set. So part of the role of whoever's planning, and in our institution it's the physicist, in some other institutions it could be a dosimetrist, the practice actually varies. One of the first jobs is to actually tell the treatment planning system where the source can possibly be. Okay, sorry, I've lost Zoom. Can you guys still hear me? I don't actually know. Yes. Okay.
You can still hear you.
Okay, so the first part is to tell, like, where can my source go here? So the old methodology was to always manually kind of register, we still register manually, but basically you have to create channels within this space. So the way this works right now, and at least in this system, there is a CAD model of a particular applicator that exists, and it has a source path, an average source path measurement that is our job to verify during commissioning. So let's say I want to position the CAD model of this 22 millimeter ovoid and 5 centimeter tandem. So because I've commissioned the CAD model, I know how I'm going to place it, especially on MRI. For those familiar with MRI, you could see that because this is plastic, the applicators are plastic, you're getting effectively a void. And within the applicator, we have fluid markers that go into the tandem right here and into the ovoids. You can see that. You see they're going through the ovoids, and as you go into the head of the ovoid right underneath the cervix, it goes around the ovoids. Okay, so now my job is, or whoever's job is, going to position this here. So I'm going to very quickly, oops, sorry, that's wrong. Sorry, it's slow because I'm remotely logged in. Apologies.
Sorry, Alex, can I interrupt briefly?
Yeah.
What are the, you said that these channels are filled with fluid. What's the fluid?
So the channels are not filled with fluid. The channels have a fluid marker inside them. So there are basically just plastic fluid markers that snap into the applicators, and you can fill them with potentially whatever you want. There's no need to actually fill them with contrast because this is T2 weighted MRI. Water will do just fine.
Oh, okay, thank you.
No problem. Okay, so now I've put some points and I've clearly screwed it up. Hold on a second. Sorry. It's very obvious when you mess up. There you go. Okay. That's also not correct. Limitive. Okay, hold on a second. First marker. There we go. So I'm getting impatient because this has a delay when I'm clicking. That normally doesn't happen if I'm sitting in front of the actual system. Okay, so now I've put several points and it's kind of sort of dropped for me the CAD model in place. I'm not going to stress too much about it right now, but I'm going to quickly adjust it to make sure that it actually matches with the images. And this is a bit of a challenge, and I think there's definitely people that prefer to do this on CT because you have significantly better visualization on CT. Plus, CT can be reconstructed, to whatever 1 millimeter, whereas these ones are 3 millimeter slices. So some people don't like doing it on MR, but our process, because again, it's an integrated MR suite, we don't wake the patient up to go to the CT, so everything is done on MRI alone. Okay, so I've plopped down the applicator now. You could see that if I have a decent registration, I should be able to see, for example, the needles in this case that have gone through, and I will reconstruct the needles in a second, that have gone through the applicator and into the patient, okay? So if I didn't have the interstitial needles, this is a combined intercavitary interstitial approach. What I would have done at this point is probably, if I didn't have, is just add library planning. So library plan is the kind of old school plan that was the go-to for when we were just treating 2-point A's. So to be honest, we still start with that most of the time, actually all of the time. Because it gets you, I want to say it gets you 80% there. It gets you something that was historically used for a long time, although it might not be appropriate to this particular patient, given this particular patient geometry. So I will fix that in a second. And so I'm gonna, it added a 7-grade prescription. So one of the things you saw on my slide is we had a bunch of external beam fractions, and then there was a bunch of brachytherapy fractions. Most people still use 4 separate fractions of brachy to 7 gray, prescription of 7 gray. We have now moved to 3 times 8 gray. I feel like talking about equivalent dose into fractions, and we have to combine this with external beam because the dosimetry that we make the decisions on is actually combined EQD2, assuming 45 and 25 or whatever the external beam was, the brachytherapy, and the assumption is alpha beta, for those people interested in radiobiology, alpha beta of 10 for targets and 3 for OARs. Now, I don't know if we're going to have time to go into that, but just very quickly, this is basically a starting point only. Okay, hold on, I don't like this. Okay, there we go. So again, as I promised, this starts out with the library plan. I have my normalization to points A. If I were to turn on my targets and OARs, you would be able to see, for example, that if I did not adjust for patient anatomy in this case, I would be over-treating this patient. I'm not going to go into showing you the QD2 calculation. You're going to have to take my word for it. But you see the 7-grade prescription is spilling into the sigmoid. And if you were to run this calculation for EQD2, this patient would have had a very fried sigmoid with horrible toxicities. Anyways, but what we can do in this case, because we actually do have information about the patient's anatomy, is we can modify it for this patient's anatomy. And the game here, of course, is to minimize the toxicity and maximize the effect. So what I would do here normally, and I would probably do this even before I got the contours, I would immediately come off the organs at risk, because I know that I can't be spilling into them without causing toxicity to the patient. So this is what I would do. Scroll quickly through it. Yeah, it looks fine. But luckily, this patient actually has a catheter. So the next part is that I would now add where the source can go in the interstitial catheters. This is called catheter registration. I'm only going to, in the interest of time, I'm only going to reconstruct one of them, but I'll show you how that's done. So I'm adding, for example, another catheter, and let's say I added it here, and I need to be able to see. All right, it's right here. The other thing that is important here is you want the plan to be deliverable. Again, this system doesn't know what catheter length I've used. I'm going to have to tell it. In some of the other systems, it knows, for example, that I only use a certain catheter set, and all of the maximum dual positions that the source can go to are already programmed in. But here, because this is kind of a very broad treatment planning system and I can use whatever I want, I'm the one who actually has to tell it what it is that I've put in. So in this case, I know what catheter it is. I know what the furthest distance is from the indexer length. So I did that. And then depending on the reconstruction, I have to tell it where the first dual position is with regards to the tip. Because we're in the MRI, I'm reconstructing to the void, but the first possible dual position actually exists further away. Because remember, my source has a certain size, and the way this treatment planning system works is it tells you where the center of the source is. So there's usually a bit of a buffer between the tip of the source and the end of the catheter lumen. Anyways, that's a detail, and it's very vendor specific. But the point with all of these vendors is you have to tell it what it is that you're using, because there's actually an array of applicators and catheter length, etc., that you could use. Okay, so now I've done that. I've only reconstructed one of the four just to demonstrate the concept. So let's say I want to chase this part of the tumor. Luckily, I have a catheter here. So I'm going to now activate this part of the catheter. And then I can, this is obviously overkill. I like to be very conformal in my plans, but I'm going to, as a starting point, and this is my approach to doing these types of treatment plans. I'm going to start with 1.5 seconds. If I do this manually for all of them, that gets me 95% there. So that's like a bronze. And then I can very quickly graphically adjust it. And most treatment planning systems now have this ability where you can kind of drag your isodoses to get coverage. Okay.
Lance, we have one question.
12:27.
Yeah, just like quick question. For the number of catheters, do you add that like with a try and fail thing, or how do you?
So that's an excellent question. I think it really depends on your comfort with interstitial catheters and where you got trained and how much experience you have. When we started the program back in 2014, because the patient underwent 2 insertions, so we did two insertions, each with 2 fractions. So there would be insertion number 1, the patient got fraction 1, fraction 2, because they stayed overnight with the applicator. We don't do that anymore. And then if we felt like we were missing from the first insertion, the dosimetry, we still had 50% to compensate for that. So on the subsequent insertions, this physicists usually say, oh, I would really add the needles here. And then we would worry about calculating, like, should we not? Does it make a difference? And then for the subsequent insertions, they would do it. And I still think that the people that are starting their programs still have this very cautious approach. We have been doing this for 12 years now. All of our rad-oncs are very comfortable by looking at the pre-brachy scan and saying, oh, this is going to be a 22 with a 50 with, lateral B's and D's. And there's such a tremendous amount of experience at this point and comfort that on a pre-brachy plan, you have a decent knowledge of how many you need and where they would go, at least for these types of cases where you're doing it through the cervix. Now, through the perineum, it's a little bit more difficult because we don't have an ability. That one is a little bit more wacky in terms of like trying to guess. And that one's probably would benefit from more intraoperative MRI, and that's what we do. Because our guesses on pre-brachy scans alone for the transperineal needles are not as good as they are when we're guessing the needles through the ovoids or through the ring.
Okay, interesting.
Yeah.
Thank you.
Yeah, so any questions about this? So I guess part of the treatment plan here is it optimizes both where the source goes and the amount of time it dwells to give you the dose distribution you want.
Well,
There's a lot more to it. I feel like 40 minutes is not enough.
I was gonna say I know how complicated brachy planning can be. So I know it was very fast. So thank you for the speed run through it, Alex.
No problem.
I guess if there are no other pressing questions, if you do have a question, maybe Alex, you could. I see that Julia had to leave, but would you be able to drop your email maybe in the chat
Yeah,
if
for
you have
sure.
questions? I guess I can share my screen here. So thank you everyone for being here. Thank you especially to our speakers. I'm sorry that Julia had to leave, but thank you so much, Dr. Rink. We really appreciate you taking the time today to talk to us about some brachy and really speed through Oncentra. I know it can be a slow and arduous process, so I appreciate it. But yeah, thank you so much everyone for being here. But that concludes our fifth session. We'll pick up again probably in August for our last session of this year. But yeah, thank you so much everyone for being here, and thank you again to our speakers.
Thank you. Have a good day. Bye-bye.
Thank
Bye.
you. Bye.